My name is Diane. I work in the neurosurgery department and I do clinical research studies for the Department of Neurosurgery. Traumatic brain injury is a serious problem worldwide, not only in the United States. There's probably about 3.5 million people that suffer a traumatic brain injury in the United States every year. Of that 3.5 million, over 2 million of them seek treatment in an emergency department. Over 300,000 of them are admitted to a hospital. 53,000 of them die from their injuries, and about 80% of those people end up with lifelong disabilities because of the brain injury that they've suffered. We look at the causes of traumatic brain injury. Falls is the #1 cause worldwide. It's very common in the young, especially in young children. It's also very common in the elderly. Motor vehicle accidents cause about 20% of all the injuries that we see, but it actually accounts for most of the deaths that we see. Struck by or struck against another object follows motor vehicles, and that's more often seen in the young population. Assault causes 10% of the injuries that we see. It's hard to determine the amount of disability that we see due to brain injuries, but a study was done recently worldwide where they looked at the outcome of 2,500 patients worldwide who had suffered a brain injury. The outcomes showed that there was about 1/3 of them that had good recovery after their brain injury. About 1/3 of them actually died from their injuries, and about 1/3 of them ended up with some type of disability after their injury, ranging from moderate disability to a severe vegetative state. So some of the facts we know about brain injury: it occurs very often in the young, from 0 to 4. It peaks again in the teenage years, and then it peaks again in the elderly. Traumatic brain injury rates, like all trauma, is much higher in males than it is in females. And about 5.3 million Americans, or about 2% of the population, is now living with the effects of suffering a traumatic brain injury. The total direct and indirect cost to the United States is about $76 billion a year. And unfortunately, little can be done to reverse the initial trauma that occurs during a brain injury. As you just talked about, most of the work that we do is supporting the injured brain and providing a good environment for the brain to recover. So what are we doing in research? Well, despite over 75 clinical trials over the past several years, none of those clinical trials have ever come up with a solution for brain injury. We actually participated in a lot of clinical trials here for brain injury, and none of them ever had a positive result. The areas that are now currently being looked at are calcium ion influx, hypothermia, magnesium sulfate, and progesterone, which is what we're going to talk about today because that was a study that Meg was enrolled in. This is a list of some of the clinical trials that have gone on over the past 20 years. We actually participated in a lot of these studies, and all of these studies failed, like I said, but probably the reason that they failed was because they only targeted one area in the secondary injury cycle. They either targeted free radicals or lipid peroxidation or calcium channel. They targeted one area, and probably one area in that cycle is not enough to prevent the secondary injury insults from occurring. So why progesterone? It seems like a weird drug to look at for brain injury. But progesterone is a hormone that we know is very prevalent in women. It plays a big role in fetal development. But several years ago, there were several anecdotal reports that women actually did better than men after traumatic brain injury. Dr. Stein and his co-workers took this into the lab, and they started doing experiments on injured mice, and found out that there was a definite difference between brain-injured mice that were females and brain-injured mice that were males. And after they worked on it for a while, they discovered that it was actually the progesterone that made a difference. They feel that the progesterone has a lot of neuroprotective effects. One of the metabolites of progesterone is a very potent neuroprotectant. And also, it's not only produced by our gonads, it's produced by the glial cells of our brain and throughout the central nervous system. So it's actually a hormone, unlike estrogen and the other hormones, that's present in the brain at very high levels. So this is another schematic of the secondary injury that occurs, like Donna was talking about. And there's several factors that go into it. And ultimately, if these are untreated, what happens is you end up with cell death in the brain. So you have ischemia, hypoxemia, inflammation. You have lots of processes. And all those other studies looked at one factor and tried to block one factor. But progesterone actually acts in several different areas of the brain. It actually blocks cerebral ischemia, it blocks neuronal apoptosis, it also decreases cerebral edema, which is a big factor after brain injury. And this is why it's felt that it looks like it's going to be a positive factor in the treatment of brain injury. There was 2 previous small studies in humans done with progesterone. One was done in the United States. It was called the PROTECT trial. And it had, they enrolled about 100 patients. They were from severe brain injury up to moderate brain injury. They enrolled Glasgow 4 to 12. And the patients were randomized 4-to-1 to placebo, or progesterone to placebo. And they treated the patients with IV progesterone for 3 days after injury. There was also a trial in China called the Shao trial, and they enrolled 160 patients. These were all severe brain injuries, and they gave IM progesterone for 5 days after injury. Both of these trials were actually safety trials. They were phase 2 trials, so they basically looked at adverse events more so than outcome. They did look a little bit at outcome, but they mostly looked at adverse events. And one of the things that was quite evident was there was no difference between the placebo-treated group and the progesterone-treated group in all of the adverse events, except for one, and that was death. There were statistically significant less deaths in the progesterone group as compared to the placebo group in both independent trials. So after they looked at the results of those studies, they found that there was a definite decrease in deaths. There was a more favorable outcome in the patients that had received the progesterone, and no meaningful difference in the adverse events that occurred. And one of the areas where they were particularly interested in were the coagulation effects of progesterone, and there was no more PEs or DVTs due to the progesterone. Which brings us to the trial that we're doing here. It's called the SYNAPSE trial. They always come up with catchy names for these studies, and it's a study of the neuroprotective activity of progesterone in severe traumatic brain injury. It's started by a company called BHR Pharma, which is a division of Besson's Pharmaceuticals. It started in 2010, in June of 2010, and it was a phase 3 multi-center pivotal trial looking at progesterone versus placebo in brain injury, after severe traumatic brain injury. The patients, we enrolled 1,180 patients in this trial across the world. The inclusion criteria included they had to have a severe brain injury, which meant a Glasgow Coma score of 3 to 8. But 3, they had to have at least one reactive pupil. That's a key factor. So we weren't enrolling people that came in fixed and dilated with a Glasgow 3. The age range was 16 to 70, and they had to be expected to survive for at least 24 hours after their injury. They were randomized 1-to-1 to either receive a placebo treatment, which was a plain lipid solution, since the progesterone is delivered in a lipid-based solution. So they either received plain placebo lipids for 5 days after injury, or they received progesterone in a lipid solution for 5 days. And the key factor was the drug had to be started within 8 hours after injury. The primary outcome for the study will be the Glasgow outcome score at 6 months after injury. The dose that was chosen for the study is actually quite high. This is the levels of normally occurring progesterone that can be measured in the bloodstream. And the highest level is when women are in their 3rd trimester of pregnancy. At that time, you can get serum levels up to 200 nanograms per milliliter. The progesterone dose that we gave allowed for levels of 300 nanograms per milliliter of progesterone. These are just a map showing more of the sites of where the study was conducted. Like I said, it was 154 sites across the world: United States, Europe, Canada, the Middle East. And the last patient was actually, jump ahead there, the last patient was actually enrolled in August of this year. And so all the patients have been enrolled. We've met our endpoint, which brings us to where we are today. Where we are today is between the point of the last patient being enrolled and the last follow-up being done. The last follow-up will be done in March of 2014. The study hopes to have all the results back to the FDA at the latest of May of 2014. And they expect to hear back from the FDA very rapidly, since this is a orphan drug and it's already received fast-track status. So it's going to be expedited once it reaches the FDA.